Welcome back to our ongoing conversation on understanding cancer treatment. I have with me in studio, if you're just joining us, a clinical oncologist, a cancer survivor, and a radiation therapist in that order, Dr. Sarah Obuya, Esther Andare, and Rose Wekesa. So earlier, Dr. we adequately tackled radiotherapy and surgery, and we were on chemotherapy. Esther here just giving us her experience, and one of the things that she talked about was the fears because of what she had read or seen or heard about when it comes to chemotherapy. The side effects, Dr. Seem to be of great concern to patients more than even the chemotherapy process itself.
Yes, and it is understood. You know, when you're put on chemotherapy, lots of changes are going to take place in your body, and these changes are systemic. Why do they take place? Because as the chemotherapy drugs fight your cancer, they also do damage to the cells.
To your body,
So you have fast producing cells, like the cells that are lining your digestive system, all the way from the mouth to down there. So you get patients presenting with sores in the mouth. They cannot swallow because they have sores in the food pipe. They have diarrhea because of, you know, the walls of the small intestine where absorption is supposed to take place are wiped off by the cancer cells. And then now you have hair falling, particularly for women. It's quite devastating for women who keep their hair. And then you have something we call bone marrow suppression, because the bone marrow cells also replicate very fast. Yeah, so it is a whole range of side effects profile, and it is systemic. And by systemic, I mean that each and every system in the body, be it the breathing system, what we call the respiratory system, be it the heart system. You know, people are so worried about hair falling, but doctors are so worried about how much, for example, a drug called doxorubicin is going to be in your body, because if you get an excess, then you get something called cardiomyopathy. We will take you into remission from, for example, your lymphoma, but then you are terminally ill from now, a heart that is not functioning well. Or your bone marrow is so suppressed, you are hardly producing white cells or red cells, and you will be very tired from the anemia because of lack of red cells, or you will get a fatal infection from arising from an low immunity, because your bone marrow cannot produce enough white cells to fight for you. So even a simple thing like a common cold will take you down. Yes.
Okay. So that is to say there is so much more good that chemo does compared to the side effects that cancer patients tend to struggle with,
Absolutely. Chemotherapy is also a precise science, just like radiotherapy. We need to know the patients that we are subjecting to chemotherapy, what stage is their cancer. Our goal of putting you on chemotherapy, is it palliative or is it radical treatment? And if it is radical treatment, is it together with radiotherapy, something we call concomitant chemoradiation? You will come across these patients who tell you, I am going on the machine every day, but each week I get a drug. That one we say that is concomitant chemoradiation. And when you have concomitant chemoradiation, your side effect profile goes up, and you need to see your doctor very closely. And so it is a whole profile of side effect that patients need to understand before we start on treatment. Not every patient qualifies to get chemotherapy for one reason or another. If your bone marrow is not working well, if your kidneys are not working well, if your liver is not working well, then it is a time to make them be better before we continue with the
chemo. Yes. Carol, sorry, Esther, I have feedback for you here from Carol Kariuki. She says, very impressive, excited to see cancer in Atiba. Yeah, I think that's for you. Very encouraging. Yeah, so you start chemotherapy and your greatest fear was hair falling off. Dr. here says there's so much more that doctors are concerned with and so much good that chemotherapy goes to do in treatment and management of cancer, and that we should worry less about the falling of hair and other small and other side effects. But you went through it. So what was your experience like?
Well, now when we embarked on treatment, of course, with the surgery, my blood was quite low.
Okay.
So I had to get a transfusion first. And then now, during surgery, they say now they found it had moved to the fallopian tube.
It had spread.
Yeah, it had spread. So after the hysterectomy, Daktari, now I was put on chemo after. Yes, so now that is now where the treatment actually begins, for us. And it was, you know, the first one, when I went through it,
The first
I felt
session.
like
How many sessions did doctors
6.
recommend for you?
6. I felt like they had been lying about chemotherapy because I walked out walking and I was just fine. So I said,
I can do
it
this.
is just this small thing people are afraid of. So, but as I went on, I realized, it is not as easy as it seems, because then now the things started changing. The weakness came in.
At what session now? At around the...
I think for me it hit right at the second one.
At the
You know,
second
at the
session.
first one, it started before I went for the second.
Okay.
So the second one, I lost my appetite a bit. The nausea started. And with this treatment, Daktari will explain that they prescribe drugs for the nausea. Then the drug that they prescribed they prescribe the drug for pain, which of course now causes the nausea. Then they give you the drug for nausea, which gives you indigestion. Then they give you the drug for indigestion, which ends up giving you diarrhea. So it's like that.
It's like a vicious
It's like
cycle.
a vicious cycle. So you're always sick. If you stop the drug which helps you with nausea, it means you go through the pain. But then again, if you stop the drug now that helps you with the nausea, then you suffer even more. You're always in the toilet, throwing up, not able to eat.
You're not able even to apply yourself, let's say at
Exactly.
work.
And there's pain in the body. It's just that people don't understand. I wasn't able to take a shower for 5 days because even that water felt really painful on my skin. I felt like I was burning at most times. Because my kids were young, I tried to hide so much of my pain from them. And my son was 6 years at that time. He quite didn't understand, but he knew I was sick, though he didn't understand what it was from. And as a mother, I'll tell you, with experience with treatment, you don't stop being a mother. See, even when you're lying on that bed, sick, you can't get up, your child will still come to the bedroom and ask you for money for bread. So, as a patient, you choose on what to live for. You decide, this is why I'm fighting. I'm fighting because these are my children. And I'm fighting because if I succumb to this, then who takes care of them? So you put them first and proceed with the treatment. And that is what happened for me. Unfortunately, I wasn't lucky to keep the father of my children. He somehow disappeared, and
it's strained your relationship.
Very,
we'll come to that, but I want to bring Rose in. We have situations where a patient who's in for radiotherapy has also scheduled chemotherapy. So how does that work? And how do you manage as professionals in the field to ensure that it's a smooth process? And I want to imagine at times you'd go out of your way to just offer even support that is beyond your job description. Because assuming a patient has chemotherapy, let's say once a week, and radio every other day, so and they call you and they tell you, Rose, I'm on this side of chemo, but I need to come to radio. Like, what sort of support does it take professionals like you to ensure that patients who are doing both chemo and radio are able to go through the treatment?
What I would like to say is it's often, actually, like most of the treatments that we do see, except maybe breast, okay, the cases like breast, those ones don't get to go hand in hand with chemotherapy. But most treatments that we are giving radiation, they have to do with chemo concurrently. Luckily, it's just once a week for the chemotherapy. It's not a daily thing like radiotherapy.
Yeah.
So if the patient is going for chemotherapy, we are in the process. We have to know. We talk to the patient, tell them to start early for the chemotherapy and then come for radiation after treatment. There are situations where the chemo is given for 24 hours. So at times then they have to come early to us, and then the following day you have to wait till late. So we've gone beyond our working hours that we can extend after the working hours to stay back and treat this patient, because you know the importance of treating the patient after chemotherapy. So you can't just assume that it's late, it's 7 o'clock and I have to go home.
Beyond my working hours, yes.
So we can't just close out the day like that. We have now to look back and say, what are we offering for our patients? We want the best for them. And even now, going just slightly beyond, other than just the treatment, when I was a student in Cape Town, what we were doing, we were even going to an extent of contributing for the patients. Because they come late, they don't have treatment to get back home. So we have to contribute. We were doing on a Friday contribution, give some money for their transport once they have been treated. It's a journey, but then we are in it together.
Yeah, Dr. was saying you become very close friends with cancer patients. Yeah, best friends, I would say. Yeah. Dr. we have feedback here from Moses and Ndege, my colleague. He says, I believe early diagnosis and proper counseling are the first and very important steps towards progressive treatment and healing process. Now, early diagnosis is a conversation that has been tackled in very many platforms, Dr. But my question now would be, after early diagnosis, I would imagine doctors want immediate treatment or also early management of cancer. But when we look at the infrastructure we have in the country, for instance, here in the North Rift and in Western Kenya, we only have one radiotherapy machine at government facilities. So how do we ensure that early diagnosis goes hand in hand with early treatment with regards having infrastructure to treat people? Because you'll find a cancer patient who's been recommended for radiotherapy at Moi Teaching and Referral Hospital being told, come back after 3 months, come back after 4 months. So we have early diagnosis, yes, but there's a challenge in early treatment, Doc.
This is a very important comment. Important in that most cancers, if we had screening and early detection, we would be having cancer survivors as living as long as 20 or 30 years
like Esther here.
Post-diagnosis.
Yes.
Because, you know, when you get cancer in stage 1, stage 2 disease, basically is curable with the very limited resources. However, I am so happy and actually very excited that now we have radiotherapy machines. West of Nakuru.
Yes.
2-3 years ago, before Ekura came into being, and then subsequently MTRH brought their LINAC machine. The only radiotherapy machine was in Nairobi,
at the
Kenyatta National Hospital. Then the next one was in Mulago, in Kampala. Now you can imagine that distance. So in North Rift, particularly in MTRH, we are very happy. And I would want to tell you that we are actually installing a second LINAC machine in MTRH. So in Eldoret, in the next few months, we will be having 3 machines. 2 at MTRH and 1 at the Eldoret Hospital. That is such a big improvement. The reason why the patients will come and they're told, come after 3 months, because you've been worked up, we have a diagnosis, we have a stage. But then when you go to the radiation machine point, there are other people waiting. Like we are told you that it's done in sessions. So we can't stop your session, Wangoi, because somebody else has just come and needs to start. No, your session continues to...
It has been non-stop once you start
to completion, because of something called radiobiology. You know, the radiation acts on the cells to suppress or stop their growth. If you stop the radiation, they start again, and now they start multiplying viciously. So that radiobiology has to be taken into account, and it must be done according to prescription in time and dose. So you have to wait to begin. What is the challenge of waiting for 3 months? If if you are at stage 2 disease, potentially curable and going into remission for quite a long time, probably when you come at the 3rd month, either now you are in stage 4 with a worse outcome, or your disease has spread beyond. Now you won't even benefit from. So in this election year, I am not a politician, but if you are, whoever is vying is not talking about health, and particularly is not telling you what they are going to do with improving cancer therapy units, then don't vote for them. Yes.
Okay.
Well, and allow me to just add on to what Daktari has said, because now I'm speaking from the point of view of a patient.
From the horse's mouth.
You see, now the doctors do what they can, because you've gone you've had your diagnosis, they've seen you, they've given your prescription, like for radiotherapy, you're ready to begin. She's done her part, the patient is ready to begin treatment. Then you go at the radiotherapy unit and you find that it's in June. That's the earliest date you can get. So it's not because you don't want to start treatment, and it's not because the doctors have not done their diagnosis. Part. So see now what happens with patients, and let me just be very frank about this, and that's why I'm not very happy with what is happening with these politicians who make a lot of noise, like Daktari said. A patient will come all the way from West Pokot.
Okay.
Daktari will attest to what I'm saying. This patient does not live in Eldoret. This patient has nowhere to sleep when they come for the sessions for radiotherapy. Say, for instance, it's the 30 sessions, So you can't ask a patient from West Pokot to go back to West Pokot and come back tomorrow. So they need a place to stay. They'll need a place where they can be comfortable, because and a caregiver as well. So what fails us now, as I speak today, is accommodation for these patients, and that is where now, as survivors, have come out, because now we are hosting these patients in our own houses. As we speak, I have one in my house, because they have nowhere to go. Most of them used to sleep at the emergency section in the hospitals, and you find now it's no longer easy for them to be there, because then they're asked to leave the hospitals. Also, being in hospitals, so you can pick quite an infection from something you were not expecting to have. So it's a challenge, and that is why these patients give up along the way, not because they do not want this treatment, but because when you're looking at the cost of what already, if you don't have NHIF, you're looking at the cost of what you want to pay, then you want to add accommodation into it. Remember, you have transport, and you are two, because it's the patient and the caregiver, and you also have to eat in the process. And remember, these people also have families back at home, and probably they are the sole providers. So when you sit down and think about it, most of them now give up. You find if a person was scheduled for some kind of treatment, they don't show up anymore. And some of them just come for after diagnosis, and they are given, and they can't afford this payment. So if there were more facilities,
and that also delays
and that
the intervention.
Exactly. So like the Daktari says, if there were more facilities, like more units for radiotherapy, and then also again, I wish the government would embrace cancer like they did HIV, because then it would be easier for those ones who are needy
to get support.
We wouldn't need to host these patients in our own houses. There'd be facilities. As we speak now, there's only, I think, Rescos that offers these accommodation facilities, for and only, of course, if you can afford it and if you have NHIF. Others have been known to be open, but I think they charge for accommodation.
So there's a huge cost implication.
Very, very huge.
That comes with cancer treatment.
It's not the doctors and it's not the patients.
It's the government.
It's the government that is failing us. Yes.
Rose, I want to imagine you experienced this firsthand. A patient has been told you need to do radiotherapy, you need 30 sessions, you need 23 sessions. And like Esther says, patients are really open-minded, most or largely, towards accessing and getting treatment immediately. So they come to to your unit and they say, now, Rose, I need to start immediately. Because this intervention, I have early detection, and I know it will end well if I start early intervention. But then again, you have a huge queue. Tell us, how do you handle all that? And paint for us a picture of if someone has been brought to you after diagnosis by Dr. Sarah here and they need radio, how soon can they begin treatment at our public hospitals?
Apparently, my experience has only been in private hospitals. I've not worked in public institutions. But I know that it has happened in public institutions, that the patients come and the queue is just too long for them. They're given the appointment maybe 4 months to come. But I do understand they don't have money to go to private hospitals. But in my practice, private hospitals where we've been, sometimes we get that surge as well, but it is still manageable. It's easy for us most times that we do alter our schedules. We have been treating, let's say, from 8 to 5, then we will want to adjust our schedules to start even at 6 a.m. to close at 10. At least we are able to accommodate. I can't remember an instant where in a private hospital a patient has come and we have told them that we can't accommodate you. We are always trying to do that. But I do understand, I think, the challenge with the government institution is now the cost implication that it comes when they want to move to the private institution. So
how much is a session for radiotherapy at a private hospital?
Most private centers currently are charging 6,000 a session.
6,000?
Yes.
Okay.
And NHIF is, if you have NHIF, it will pay 3,600 for one session, for only 20 sessions. So if a patient is going for like 35 sessions, they'll pay 3,600 for 20 sessions. And then the remainder the patient will be will complete. But for 3,600 again, they have to top up by 2,400 per session. Okay. I know in public institutions like Kenyatta National Hospital, Kenyatta University, and now MTRH, they're just taking the NHIF rate. So I think that thing is really putting us down and is overburdening the patients. But I don't know how the balance will come about because radiotherapy services themselves, the generation of the radiotherapy service is quite expensive. So then I can't say who is who on in terms of charging. But I like the fact that the government is now doing something. We have a center coming up in Nakuru, Mombasa. I believe that is going to debulk. To
get easier. Because Dr. I want to believe health is a basic human right, and it should not mean because Rose here has 6,000 Kenyan shillings and I have 100 Kenyan shillings. And we have both gotten diagnosed with cancer, then she is more qualified on the basis of what she has in her pocket. It's very sad.
You have to remember that nobody knows they are going to come down with cancer, so that they prepare that money for treatment.
True.
And it is a massive expense that is cropping into your normal expense. For an average Kenyan income, cancer treatment is out of reach. And you know, it is so interesting. Why would NHIF say we will only pay 3,600 per session? While if you are going for surgery, they will pay for the whole surgery. It's so intriguing. I have always asked myself that question.
What informs that? Yes.
Like they will pay for a whole knee replacement. They will reimburse a hospital up to 120,000.
Oh, wow.
And they will fail.
And that may not have a terminal scare.
It is actually not, okay, it is very inconveniencing for the patient. I appreciate it. It's a very difficult thing for the patient. But why would they not pay for this patient 6,000 shillings, the whole of it? Not so many of us are able to afford even 3,000 shillings per day for whatever. Me included, you know?
True.
So we are failing in advocacy, and we are failing in implementing the serious things that are surrounding cancer treatment.
Yeah.
Let us budget very well for health. When we budget very well for health, actually, if we just go by the Abuja Declaration of putting a certain percentage of the country's GDP to health, then we will have enough resources to take care of each and every one of us. It wouldn't matter if you're a millionaire or if you are a pauper, because there will be universal health care. I have cancer of the breast, I go to any facility, I am sure I'll get the doctor, I am sure I'll get the drugs, I am sure if I need radiotherapy, I am sure I'll get the surgeon, whether I have that money or not. Yes.
Yeah. Okay. Very interesting. And
before you cut me off, I would like to say that even doctors, the salary that a doctor gets in this country cannot afford cancer treatment. If you come to our walls, we are constantly contributing for colleagues. Yes. And it is a very sad scenario, you know, to ply a trade that you cannot afford.
I know. And if for those in employment and for those with business ventures or something to do with their lives, it becomes expensive, then how about someone who's totally not employed or they do not have a business running somewhere? And you see, gone are the days when we'd say cancer is a disease of the class of rich. Esther, I want to believe you have had experiences with Kenyans who are really struggling and with barely enough for themselves and being diagnosed with cancer.
Well, let me first start by saying that for me, just come to Eldoret during my diagnosis. I was so new. I'm also in the medical field. But I'd not started earning quite well. I just come to Eldoret, and
you were trying to find your footing financially.
Find my footing financially.
And then the cancer burden comes.
And then the cancer burden comes. I am in a new town. I don't know anyone.
It was tough.
At first, you start using your own savings as well as your NHIF, and I had one more. This private health insurance. But you know, people assume that when you have all that, that it can pay for everything.
For all the costs that you need.
Rose will come in to this point, but there was a time that Jubilee Insurance was the only one paying for radiotherapy. The other private health insurances were not within Eldoret Hospital. So NHIF was the only best option. And then now with the number of limitations they've put, now you have to go back to your pocket. Yes. So you see now with this treatment, it's not like it's only the chemotherapy you get. You're also having scans in between there. You're also having lab works in between there. And you're also having drugs that you're buying, that you're taking orally. And they're not cheap. Yes. So it's trainers now for somebody who has a job. Now imagine for someone with
who
nothing,
lacking,
no NHIF, and no source of funds. So you depend on friends and family. And I'll tell you firsthand that people get tired. Cancer is a continuous process.
Your journey began in 2015.
Yes.
And you're still managing the condition with treatment.
And there are people who will come and ask you, Yani, you've never gotten better? Hujawai pona? Things like that. And with cancer, there are always something that will come up without your knowledge. Yes, like you can have a certain complication that you need to run to the hospital
doctor again
for.
Thank you, Esther, for that one-on-one. Really, Esther painting for us a picture on cancer treatment and the financial implications and burdens that come with it. We take yet another health break. When we come back, we talk matters cancer and research and how far the medics are with regards cancer treatment and management. We take a short break. We'll be right back with that and much more.